Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. Hear about chiropractic research from the authors in plain English, not through the media nor a middleman. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I'm a clinical faculty member in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Before we get to the interview with Dr. Donald Murphy, I have some housekeeping to take care of. First of all, as a few months ago, we had surpassed 30,000 downloads of the podcast. Thanks for listening. I really appreciate all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes reviews really help others find out about chiropractic science. So if you like the show, please take a second and write a review. The time you take to write a review will strengthen chiropractic science and support chiropractors everywhere. I wanted to share a recent review on iTunes from someone with the nickname cbowls8677 who said, "I stumbled across this podcast as a trimester 2 chiropractic student. The first segment I listened to was with Dr. Bernadette Murphy, and I was hooked. Dr. Dean Smith does an incredible job of guiding the interview fluidly and asking the very questions that come to my mind while listening. As someone who wants to be involved in chiropractic research, Dr. Smith ends his interviews with, 'What advice would you have for someone interested in pursuing research?' The responses from those interviewed have been nothing short of inspiring. I'd recommend this podcast to anyone interested in neuromusculoskeletal medicine, especially manual therapists." Well, thank you so much for those kind words. I look forward to sharing your clever and flattering iTunes review in a future podcast. Please consider making a contribution to chiropractic science to keep these podcasts going. You can do so on our website at chiropracticscience.com by way of the contribution page, or simply purchase the Chiropractic Science presentation package, which are evidence-based patient education slides for your practice. We are also on social media, including Facebook and Instagram. Connect with us there to stay up to date on all the latest happenings, to learn about the latest podcasts and when they are posted. Okay, on to the podcast. Okay, well, let's get on to the interview with Dr. Donald Murphy. I'm really excited that in this interview, we'll discuss topics such as spine care as a framework for the chiropractic identity, as well as primary spine care, psychologic factors in spinal pain, lumbar spinal stenosis, and clinical reasoning in spine pain, or CRISP protocols. Dr. Murphy is medical director of the Spine Care Program for Care New England, a large multi-hospital system in Rhode Island where he oversees the development and implementation of an integrated spine care pathway. He is also clinical assistant professor in the Department of Family Medicine at Alpert Medical School of Brown University. His other faculty appointments include professor, part-time university faculty at Southern California University of Health Sciences, and adjunct associate professor of research at New York Chiropractic College. Dr. Murphy has been admitted as Fellow of the Royal College of Chiropractors in the United Kingdom. Dr. Murphy has served on the expert panel for several spine care guidelines, including those of the American College of Environmental and Occupational Medicine, American College of Physicians, and American Pain Society. Dr. Murphy has 29 years of experience practicing and teaching primary spine care and has nearly 100 publications in peer-reviewed scientific journals and book chapters. He is the lead instructor for the certification course for primary spine practitioners offered by the University of Pittsburgh. His recent books, Clinical Reasoning in Spine Pain, Volume 1 and Volume 2, serve as the required texts for that course. His consulting activities include assisting hospitals, healthcare systems, and insurers implement high-value spine care services through Spine Care Partners, LLC. Dr. Murphy, it's an honor to have you on the Chiropractic Science podcast.
Thanks. It's great to be here.
Great. Well, let's go ahead and dive into the questions I have for you today. And the first one, hopefully an easy one. How did you become interested in becoming a chiropractor?
Oh, wow. That is an easy one, although it was a long time ago. But I was always interested in health. And, I always was into physical fitness. And so, I had an interest in the health and well-being of the human body. And so I had kind of bounced around a little bit. I went to school for 2 years, and my initial major was theater. I decided that I didn't want to pursue that acting as a career, but I didn't know what I wanted to do. And so, but I did always have an interest in health and physical fitness. And so I ended up speaking to a friend of mine who was getting ready to start New York Chiropractic College, and he started telling me about chiropractic. And the more he talked about it, the more interesting it became. So I started investigating it a bit, and found that it really interested me in terms of my interest in health and wellness and fitness. So I said, okay, this is what I want to do, and that's where I went.
That's terrific. Now, Dr. Murphy, your career is exemplary of the scientist-practitioner model. When and how did you become interested in research and then ultimately contributing to chiropractic science through journal publications?
Well, as I was going through my schooling and then my career, I was filled with questions about how to best identify problems that exist in people that are causing them to suffer, how to best address those problems. And, I found that my professors at school had a lot of answers, but they were unable to answer a lot of my questions just because of the state of the knowledge base. I went out in my career and I started, subscribing to journals and reading books and really absorbing myself into the scientific literature, and learned a great deal. Started traveling around the country and around the world, taking seminars and spending time with high quality practitioners around the world, and learned a lot as well. But it seemed like the more I learned, the more questions I had, and so I realized that the literature only provides so much of the answers to my burning questions. So if I'm going to seek the answers to those questions, I'm going to have to go about the process of seeking them myself, and that led me into a research career. And what I was really passionate about was doing relevant research that really helped clinicians better care for their patients. And I felt that the best way to do that would be as a clinician/scientist, somebody who's actually functioning as a clinician, treating patients, seeing patients every day, encountering the challenges that clinicians encounter, but also asking and seeking the answer to those questions that arise as to how best to help patients.
That's terrific. I really appreciate all of the work that you do and the knowledge and experience that you have. I'm just curious, after all of these years of practice and publishing, do you still have lots of burning questions?
I still have a burning passion to learn more knowledge and experience, and to know more about what causes people to suffer and how I and we can best help them overcome that suffering. And all the answers have not been answered yet. And so until they are, I'm going to keep seeking and keep doing the best I can now with the knowledge that we have. And that's the one thing that you have to be mindful of, is that have the burning questions. Don't become complacent with what you know now, but accept what you know now. All you can ever do is the best you can with what you know at the present moment. And be comfortable with that. Be passionate about doing the best you can in helping your patients, but at the same time have that drive to become better, to find better ways to identify what ails patients and how we can help.
Yeah, terrific. So we'll explore some of these issues and your search for finding some of these better ways. You've authored numerous publications in a variety of excellent peer-reviewed journals. During this interview, we're going to discuss some of your interests and some of your contributions to our field. So I'll go ahead and just get started with some of these. And the first one is a very recent publication. This comes from the Journal of Chiropractic Humanities and is a paper entitled Spine Care as a Framework for the Chiropractic Identity. Could you guide us through that paper, what your main ideas were, and what practitioners and, let's say, chiropractic students and anybody interested in chiropractic can take away from this paper?
Yes, this is a topic that I've been thinking about, talking about, and writing about for some time. And I spoke with Dr. Michael Schneider. We have all been thinking and writing and talking, sometimes with each other, sometimes on our own, about this topic. And so we decided to put together a paper. I had been the lead author of two papers several years ago that were published on this topic, and we decided, I think it's a good idea to update this topic and to address it in light of what has gone on in the evolution of the spine care world and in the evolution of the chiropractic world in the ensuing years since we had written those original papers. And basically, it was our position that the chiropractic profession has been in existence for over 100 years, well over 100 years at this point, and it has achieved great strides in terms of becoming better accepted within mainstream healthcare and within mainstream society. But we really feel that we have a ways to go before we really become fully integrated into mainstream society and mainstream healthcare. And so one of the things that has been a problem for us, we saw, is that we've never carved out for ourselves a clear identity. Who are we, and what do we do, and what do we have to offer the healthcare world? We kind of have been functioning in our own little cocoon, as it were. And we had our population of patients, and by and large, our patients are very, very happy with our services. But there are lots of people out there that are not seeing chiropractors. And so we recognize that a successful profession is one that is formed in response to a clear societal need. And so we decided to look at chiropractic and the desire of the chiropractic profession, and certainly our desire for the chiropractic profession, to become more ingrained in the mainstream of society and to have greater utilization by society. And so we decided to look at that from the framework of, well, what do successful professions do? They respond to a societal need that society has determined it needs, rather than the profession determining what that need is, and then responding to that need in the most high quality way possible. And so we said, well, what skills do chiropractors have that respond to an existing societal need that society has recognized that is out there? And so we, number one, saw in society, in healthcare, the absolute mess that spine care is. Spine care in our society is highly expensive and highly ineffective and highly inefficient. And so this is a real problem, and we have problems in our healthcare system in general in terms of efficiency and cost effectiveness, but nowhere is it more stark than in the area of spine care. Then we looked at the chiropractic profession, and we thought, well, what knowledge and skills do they have that they have more than any other? In what area do chiropractors have knowledge and skills that they have more than in any other area? And clearly, it's spine. Most of our education is on spine. We have a eclectic education in terms of anatomy and physiology and pathology and differential diagnosis, but the majority of our clinical training is in the spine. So really, if we're going to establish ourselves as a profession that has something of value to offer society in an area that society has a real acknowledged and perceived need, it's spine care. And so that's the basis of that paper.
Okay, terrific. Yeah, no question. The society everywhere needs somebody well-versed in spine. That's for sure. Number one disability in the world, low back pain, right? So it's a huge issue everywhere.
Right.
Well,
and neck pain is number 4.
Yeah, exactly. Exactly right. So spine as a whole is just incredible. So in this paper and in your viewpoint then, are chiropractors specialists?
Yes, I would say that chiropractors are specialists in the sense that they specialize in a very focused area of healthcare, and that is spine. The analogy, the best analogy would be the general dentist. One can say that the general dentist is a specialist. One can also argue that the general dentist is a primary care person, but in a specific area, that is in oral health. And so we're a specialist from that standpoint. Another analogy would be optometry or podiatry, that we focus on a specific area of health that we have a unique skill set in that other practitioners don't have.
Okay. What is primary spine care?
Primary spine care is also an area that I've done a lot of thinking, writing, talking, and discussing about. And this is a new role in the healthcare system that I am part of a movement, certainly not the only part, but I am part of a movement in introducing this as a new service line, a new practitioner type in the healthcare system. That is primary care for patients with spine problems. Again, getting back to the dentist analogy, the general dentist is the primary care person for patients with oral health. We also have specialists in that area, periodontist, endodontist, etc. But the general dentist is the first person, the go-to person that people go to for oral health problems, and that the general dentist is able to manage the majority without the need for referral to specialists. However, specialists are available when they're needed. And so that analogy isn't a perfect analogy, but that basically what primary spine care is. Primary spine care is, number one, have the knowledge and skills to manage the majority without the need for referral, but also to be able to make decisions with regard to differential diagnosis if further diagnostic evaluation is needed, if specialist consult or specialist services are needed, injection, surgery, acupuncture, behavioral health, or whatever may be the case in terms of the individual patient's needs. And then also, importantly, to follow up with the patient after they've received that diagnostic workup or received that specialty services, and then determine from there, okay, where are we at now? How are you doing now? What do we need to do at this point, if anything, to accelerate you on the road to recovery and to guide that patient on the road to recovery? This means having skills in number one, the biopsychosocial model of spine care. That is, what are the specific biological, psychological, and social factors that contribute to the spine pain experience? The ability to identify those factors, in addition to identifying pathological factors that may be producing the patient's spine problem, but also being able to coordinate the services of a variety of practitioners out there who may have something to offer this patient, and to be able to follow up with the patient and, again, keep them on track toward recovery. And so that would be the role of the primary spine practitioner, similar to the primary care doctor, the general internist, or the family medicine, the role that they play in most other areas of healthcare. This would be the role of the primary spine practitioner, except specifically for patients with spine problems.
Okay, very good. So the chiropractors that are in practice now, how would they get to that level of primary spine care? Is there a certification program that they would go through? Is that how you envision it? And could you tell me about that, if there is such?
Yeah, chiropractors are the professionals that are closest to having the knowledge and skills necessary to play this role. We don't get all of the knowledge and skills that we need to play this role in chiropractic school, but we have a good foundation that can be built upon that to then transition into that role of primary spine practitioner. And so I've had the good fortune of being part of a team that has developed a certification course through the University of Pittsburgh in conjunction with the Southern California University of Health Sciences to develop a curriculum for a one-year course that trains practitioners who have the appropriate background to be able to be trained to become primary spine practitioners. Chiropractors have that appropriate background. And so this is a one-year course which ends up with certification through the University of Pittsburgh that involves 5 units. Each unit has a live weekend class and then a group of online courses. And there are 5 written tests and then a practical test at the end that people will have to pass in order to gain certification as a primary spine practitioner.
Okay, very good. Now, is that program already up and going? And if so, how do people apply?
It's in the process. It's almost complete. We actually have a date scheduled for the first weekend in December. The first weekend of December is the weekend of Unit 1. And we're expecting the online courses for Unit 1 to be up and running by late summer or early fall, so people can enroll in the course, start taking the distance learning classes in preparation for the live class in December. But things are still in the process of being finalized. So the course, everything about the course is not finalized yet, but we're very, very close to finalizing.
Okay, very good. Let's get on to another paper, and I know you have a lot of interest and experience in this issue, and that is the usefulness of clinical measures of psychological factors in patients with spine pain and dealing with psychological factors in practice. So the paper I'd like to discuss, and certainly any other issues you'd like to bring up about psychological factors, comes from JMPT in 2011. Can you tell us about that paper?
Yes. The evolution of this came from my, as I was talking about earlier, my study of the literature and of clinical observations of patients over the years, and becoming increasingly aware of the role that psychological factors play in the perpetuation of the ongoing pain, disability, and suffering experience that people undergo and people see us for. And so it became more and more clear over time that these psychological factors are very important. And so, I never dreamed when I graduated from New York Chiropractic College in 1988 that I would end as much as I now, because if I was going to help them overcome the problem, I needed to understand what the problem was. And a lot of what was perpetuating the problem were these normal but unhelpful psychological processes that people go through when they have a spine pain experience. So what led to this paper was again, getting back to what I was talking about as a clinician-scientist, my desire to be able to identify these psychological factors in my patients in a way that is clinically efficient, in a way that could be applied in a busy clinical environment, which is where I was functioning. And so and this has been the case with all of my clinical work and my research, is finding ways not just to identify what the factors are that are producing the pain, disability, and suffering experience, but also ways in which I can detect these in a manner that is able to be applied in a busy clinical environment. So if you need to do a diagnostic test that requires 20 minutes to perform one test, well, that's not an efficient way of conducting a practice. So because there's so many other different things that you have to do in the context of a new patient exam, for example. And the same thing with psychological factors. There are lots of different questionnaires out there that you can give to patients and they can answer, and you can gain a lot of high-quality information about their perceptions and their emotional responses and their psychological cognitions about this problem. But do you make your patients sit there for an hour filling out questionnaires? Well, they're not they're going to walk out the door. So anything that you do that is bringing you diagnostic information has to be applicable to a busy clinical environment, or else it's just not useful. And so this is where this paper came from. I found in the literature some instruments that ask questions about psychological perpetuating factors, and I wanted to find out, okay, is this brief battery of questionnaires, is this useful in terms of gaining important clinical psychological information? So in this particular study, we used the 11-item Tampa scale for kinesiophobia. Kinesiophobia, basically, literally by name, it means fear of movement. And so the original Tampa scale was a 17-question scale, but I had discovered a paper that pared it down to 11 questions and found that the 11-question questionnaire was just as effective as the 17-question. And I also found in the literature a coping screen that asked two questions taken from a larger questionnaire called the Coping Strategies Questionnaire. That also, these two questions, the findings compared fairly well with the larger questionnaire. And then I looked at the Bournemouth Disability Questionnaire, which is an outcome measure, but has a depression scale and an anxiety scale. Just one simple question that gives you information about depression and anxiety. And so we looked at, almost 400 patients with neck or back pain, and found that, number one, having people answer these simple questionnaires at baseline and at re-exam, because you want to know if their improvement is occurring, was well tolerated, well accepted by patients. So patients were willing to spend the time, which is only a few minutes, to answer these questions, but also gave us quality information in terms of the psychological constructs. And we found that these questionnaires that we're studying look at different psychological factors that can contribute to the spine pain experience: fear, anxiety, depression, coping strategies. So, and we found when we look at the data that it is important to look at a number of different psychological factors, that you don't have to look at every psychological factor that could possibly be contributing. But it is important to look at more than one, to look at a variety, because there's a certain amount of overlap. But it's not a situation where, okay, if you've got one, you've got them all. So we felt that we had found a pretty good balance of looking at different constructs, while at the same time making it efficient and not burdensome to the patient.
Okay, thanks for that explanation. Which psychological measures would you recommend for, let's say, a busy chiropractor in practice to use? Yeah, so certainly in this paper, my thinking and my study of this topic has evolved since that time. But certainly this paper would show that if you can simply use the Tampa scale, those 11 questions, the 2-question coping strategy screen, and the Bournemouth Disability Questionnaire, which has a depression and anxiety scale, you're getting a pretty
good assessment of their psychological status and whether there are clinically meaningful psychological factors that are contributing. And you can have them answer these questions at re-exam. You can document whether they're improving in these areas. And so that's a fairly efficient way of going about asking questions and finding out the answers.
Okay, perfect. So you'd recommend then to use these scales at new patient intake and then any reassessments down the road so you can follow up on those improvements, hopefully, in that.
Yes, hopefully improvements. And if they're not improving, that's important information too. What do I need to do about it?
Exactly. Well, since these psychological factors do have high correlations to neck and back pain, at what point in time would you suggest that our patients who have these issues be co-managed for their psychological issues, and who do you think chiropractors might want to refer to?
Right. So this is, again, the usefulness of having them complete these kinds of questionnaires both at baseline and at re-exam, because if at the first re-exam, or maybe the second re-exam, if you want to kind of give them a little bit of an opportunity to improve with chiropractic care, because I'll back up and say that with standard chiropractic care or with primary spine care, if that's what you're practicing, a lot of these psychological factors will improve as their somatic factors improve. So if they have high fear or depression or anxiety or problematic coping or low self-efficacy in the beginning, many will improve with your care. But those that don't at the first re-exam, or certainly by the second, if they're not experiencing and demonstrating quantitatively significant improvement, that's when you want to seek the services of a psychologist. And specifically what you want to look for is a psychologist who's trained in either cognitive behavioral therapy or acceptance and commitment therapy, or preferably both, specifically for pain. So in other words, a psychologist being trained in cognitive behavioral therapy or acceptance and commitment therapy, but not specifically for pain, well, they can be useful, but even better would be somebody who's trained in applying those psychological techniques specifically in patients in pain, which is a kind of a very focused area. So what the chiropractor is going to want to do is go around the community, look around the community, and communicate with psychologists, and many social workers have these skills also, and find out who has that training in, again, either cognitive behavioral therapy or commitment or acceptance and commitment therapy, or both, specifically for pain.
Excellent. Yeah, excellent advice. Well, let's take a look at another paper or another trial. And actually, I don't think this has been published yet. Maybe you can correct me, but this is the lumbar spinal stenosis trial. And I know you presented, or your team presented the work at DC 2017 not too long ago. But maybe you can take it over from here and tell us about that trial if you feel comfortable talking about that trial pre-publication.
Sure, absolutely. Spinal stenosis has been an area of keen interest of mine for some time. As a matter of fact, partly with this trial, this randomized control trial that we recently conducted, the genesis of that was in an observational that spinal stenosis is a very common problem. And when you look at the literature in terms of non-surgical approaches to spinal stenosis, there's very little out there. There's very little in the literature as to what people can do non-surgically to overcome spinal stenosis. Meanwhile, in my practice, I had developed a protocol for treating spinal stenosis that seemed to me, just by critical observation, seemed to me to be helpful. One thing that I've learned in practice is that if you think you're getting good results, don't leave it at that. systematically measure your results, because you may be surprised at what you find. But certainly, it seemed to me that I was getting good results with patients with spinal stenosis with this protocol that I'll talk about what the protocol is in a second. And so I said, well, I want to see if I'm right. If my critical observation is right, am I getting as good outcomes as I think? So I conducted an observational study where we looked at I think it was 59. It's been a while since I looked at the study. 59 patients with spinal stenosis, consecutive patients, and we were measuring our outcomes as part of our normal conducting of clinical practice. And I applied the protocol I had been using, which is focused on distraction manipulation, or some people call it flexion distraction, or some people call it Cox technique. Distraction manipulation combined with neural mobilization of the involved nerve root. That is, exercises and manual treatments to mobilize the involved nerve root, along with distraction manipulation designed to mobilize the segment that is stenotic. And so what we found was that there was clinically meaningful improvement. We used the Roland-Morris questionnaire as our primary outcome measure at that time. Clinically meaningful improvement in Roland-Morris questionnaire occurred from baseline to the end of treatment. Then we followed up with patients an average of 16.5 months afterward, and found that their improvement had been maintained over almost a year and a half after stopping treatment.
Wow.
And so again, what I found with my critical observation was validated or supported by these results, that we get good outcomes from the improvement is maintained over a year and a half. And patients are instructed to stay with your exercises and keep that the neural mobilization exercises, keep that nerve root moving. The spine mobilization exercises, keep your spine moving. We didn't monitor the compliance with that, but certainly that was our approach. But whatever the reason, their improvement was maintained. So this led to one thing led to another, and led to the design of this randomized controlled trial to compare three groups. One group received a similar protocol, and I'm going to back up for a second. What we discovered also while we were developing this trial was that there was a doctor in Toronto, Carlo Amin Dolia, who was also treating a lot of people with spinal stenosis, who was also using a protocol very similar to ours, focused on distraction manipulation, side posture manipulation in addition, and that was our approach as well. Not only distraction, but in those who needed it, side posture manipulation, neural mobilization, exercises. Except he organized it into a boot camp. That when you come in here for stenosis care, you're enrolled in a boot camp, and you're expected to comply with your exercises and you make your visits, visit appointments, and really dedicate yourself to overcoming this problem, because the only alternative is surgery, and so, which is an interesting thing that I'll talk about in a second. So we designed this trial kind of combining the two protocols, which again were very, very similar. And we used the Swiss Spinal Stenosis Questionnaire, which is a questionnaire similar to like the Oswestry or the Roland-Morris or the Neck Disability Index, the Bournemouth questionnaire that we're all familiar with, but it's specific to stenosis. And we also used the self-paced walking test, which is simply a test where people walk a certain distance, and they stop when at the point at which, in their perception, pain causes them to have to stop. And so we compared three groups. Number one was usual medical care, where they saw a physiatrist, and the physiatrist just did whatever he or she would normally do: medication, advice, exercise, sometimes epidural steroid injection. The second group was group exercise, where they enrolled in a community exercise designed to specifically target elderly people, just getting them exercising, getting them moving, etc. And then the third arm was our manual therapy and exercise, we called it, arm, which is basically the protocol. And we found that that we followed them up so far at 2 months and 6 months. We haven't done long-term follow-ups yet because not enough time has passed yet. But what we found was that there was significant improvement in the Swiss spinal stenosis questionnaire in the protocol group compared to the other two groups. The protocol group fared better in all of the different outcome measures than the other two groups, but the change in the Swiss spinal stenosis questionnaire in particular was a significant change. But what we also did, and this is really important, and for those of your listeners who are budding scientists, I really think this is important to do a responder analysis, where you look at not only how each group did on average, but you look at how many people in this group had a clinically meaningful improvement, how many people in that group had a clinically meaningful improvement, where you can really look at each group. What was there a significant number of people who benefited? And what we found was in all of the outcome measures in the responder analysis, a greater percentage of people had a positive response in the protocol group compared to the other two groups. So this was encouraging because it's one of the rare randomized controlled trials that have been done on non-surgical management of patients with spinal stenosis. Now, I'll encourage you to interview Dr. Amin Dolia, who did he did his own trial of his boot camp approach, which was interesting because from a protocol standpoint, what the practitioners did on each visit is almost identical in his trial, except he had the boot camp environment, where again, patients are expected to commit to this, and you're going to do your exercises, and you're enrolled in a boot camp, and it's that environment that is different in his trial compared to ours, and his results were actually better than ours. And I really think that boot camp environment is what makes the difference. Really getting people committed to I'm going to get better. This is my one chance to improve, because the only thing that's left is surgery, and I'm going to commit to this, and I'm going to do my exercises, and I'm going to and I have a doctor, the chiropractor who's going to be on top of me and making sure I'm doing my exercises, and I'm committed to this thing. That environment seems to create an even better outcome than just providing the actual techniques, which in and of themselves produce a beneficial response. But the environment it takes it to the next level. So I really think this will be an important line of research because for many people, and it's funny when I talk about this, when I have meetings regularly with the neurosurgeons and orthopedic spine surgeons, and especially the neurosurgeons, they just can't get their head around the possibility that spinal stenosis can improve non-surgically, because there is an anatomical change. And in their mind, there's no way this patient can possibly get better unless you fix the anatomy, take out those osteophytes and that hypertrophied ligamentum flavum, and that's the only possible way this person can possibly improve. And I keep making the point that the human body can handle a little bit of pathoanatomy as long as physiology and psychology is right. And so if you can appropriately address physiology and biomechanics and psychology, many patients their human body is very adaptable to this change in anatomy. And so it's really an interesting discussion, but of course the data speaks for itself. The fact is we can help people with spinal stenosis, and we can help them avoid surgery.
Wow, this is really fascinating. I appreciate your thorough explanation of the trial and the pre-study that you did and all of your explanations here. This is really amazing, and the boot camp sounds amazing too. Just curious, since you've seen the results of the trial, have you tried to implement in your own practice some of the boot camp ideas? Getting people really engaged and
Yes, that's exactly, because again, the remainder of the protocol was my protocol. It was that maximizes the ability of the patient to get a better outcome. And was one thing that I could spend another hour talking about, and maybe someday we can. But context it has a huge impact on outcome. So the things that you do mechanically that we tend to put so much importance on, the manipulation, how you do it, the exercise, how the patient's performing it, how you show them, etc. Those things are all important, but the context in which you're doing those things really makes a huge difference in terms of their improvement. And so that's where the boot camp concept has really influenced me.
Perfect. Well, I want to spend a little bit of time in talking about your two books, the Clinical Reasoning in Spine Pain, or CRISP protocols. And I know you have 2 volumes. I've looked through your first volume, haven't had a chance to read the second volume yet, but can you tell us and the audience what these 2 books are all about?
Well, again, in my evolution as a clinician/scientist, I've looked at all of the literature, and kind of whenever I read a study, I look at it in the context of, okay, how can this help me better help my patients? And so I've examined the entire world literature, traveled the world learning from people, and found commonalities. There's a lot of stuff out there. There are a lot of things that have been shown to be helpful. Most of them, when you look at randomized controlled trials, they only help a little bit. But if you take the different things from these different schools of thought, from these different studies, and you put them into a clinical reasoning process by which you can determine who needs what when. You have all these different treatment approaches. You have communication approaches, all of which have evidence of benefit. But the key is, what do I need to do in what patient and at what point in the care process? That really gets at the heart of efficiency. And applying evidence-based practice, that's really important, and that's the buzzword. But how do you apply it in a way that's clinically efficient, that allows you to have an organized thinking process that allows you to apply the evidence-based approach? And that became my next obsession, if you will. And that culminated in the CRISP protocols, where it's simply a way to look at the biopsychosocial model, right? All the biological factors that can contribute to the pain, disability, and suffering experience, the psychological factors, the social context in which they live, looking at what contribute to this patient's problem, finding out using reliable and valid means, finding out, okay, in this particular individual, what are the key factors that are contributing to their problem? And using this clinical reasoning process to come up with a diagnosis. And because spinal pain is multifactorial, the diagnosis has multiple factors to them. There are somatic factors, there are neurophysiological factors, there are psychological factors. Identifying what are the key factors in this particular individual patient. And once I identify them, then what is the best thing to do to address those factors to improve their situation and help them overcome the problem? And so the CRISP protocols, clinical reasoning in spine pain, is simply applying this clinical reasoning process to identify the key factors in each individual patient and to come up with a treatment plan that specifically addresses those factors, and all of it based on the evidence that's out there in the literature. So it's evidence-based, it applies the biopsychosocial model, and it's practical in a busy practice environment.
Yeah, very good. Well, I'd highly encourage everyone to check out your Clinical Reasoning and Spine Pain Protocol books, Volume 1 and Volume 2. Fascinating. I can't wait to...
They're available on Amazon.com, just to let you know.
Okay, terrific. And I'll put a link. I'll put a link to the textbooks as well from the podcast so that people can check those out. That's great. Well, I'm curious with all of your research and your busy practice life. I'm just curious because I am in practice, but I'm only in practice part-time, and I teach and do research also. So maybe this is just for me, but I'm sure lots of other people want to know how to do this too. But what are some of the strategies that you use? For example, you read an article, you get really excited. Oh, wow, I need to incorporate that somehow into practice. What do you do? Do you just go ahead and implement it right away? Do you think about how it's going to fit best into your efficiency? How do you go about that process? I'm just curious.
Yep. And again, one thing that I've been really adamant about is efficiency, efficiency, efficiency. So whenever I learn something new, that's the first thing I think of is how does this fit into the big picture? And that's the other important thing is always having a big picture in mind. Okay. And so for me, the way I organize my thinking of the big picture is the CRISP protocols. Okay. That gives me first gives me the big picture, but then it gives me the specifics that I need to apply. And, okay, where does this patient fit into the big picture? Or if I learn something new, where does this new knowledge or this new skill fit into the big picture? And always starting with that big picture is really helpful because then you have to use the word again, context, in which this new knowledge that I've obtained is now meaningful because I figured out how to fit it into the big picture. And I think, again, coming from that big picture orientation, and then looking at each piece of knowledge or skill and looking at how that fits into the big picture is the efficient way to go about this. Okay,
very good. Very good. Yeah, it's a question that I struggle with sometimes. We're both in the literature, it seems, every single day looking at lots of things, and it's hard sometimes to make it be completely efficient. So I like that step back, look at everything in the context, and then find a way to plug it into the practice. That's great.
Yes, so otherwise what happens is, and this is what I find with people who are trying to, earnestly trying to be evidence-based, is that, okay, this study comes out, okay, I have to chase after that study, I have to do this now. Then another study, okay, I have to chase after that study and start doing that now. And then another study comes out, and you're always zigzagging back and forth from one study to the next, and it really can drive you nuts, which again is why having the big picture in mind and looking at how this study fits into the big picture is so useful.
For sure, and heaven forbid that another study doesn't find the same results, right?
Yeah, and that's why, again, it's looking at this study in the context of the entire literature, because there are going to be conflicting studies. Yeah. And there are going to be seemingly conflicting studies, but when you really understand the breadth of the literature, they're not as conflicting as they appear to be, because they're looking at slightly different questions. But if you don't have the broad understanding of the entire literature, then it oftentimes looks like the studies are more conflicting than they really are.
Yes, absolutely. Well, a goal of this podcast series is to motivate and assist practitioners and students alike to pursue research careers in chiropractic science. Can you offer any advice to aspiring chiropractors or students that may wish to become scientists?
Yes. So what I suggest is number one, have a burning desire to answer important clinical questions. That should be where you're coming from. That burning desire should drive you. Number one. Number two, I would strongly urge people to always be thinking in terms of what kind of clinical questions can I ask that specifically impact patients' lives, specifically help clinicians better care for patients, specifically help patients be more equipped to help themselves. Always have the patient in mind, and you can be at a bench in a lab and still have the patient in mind. So that I think is the biggest key.
Perfect. Well, thank you, Dr. Murphy, so much for coming on the podcast today and sharing all of your wealth of information. I really appreciate all of the insight that you had to offer us.
Thank you, Dr. Smith. It was a lot of fun.
Thanks again for listening to this great interview with Dr. Donald Murphy. I hope you now have a greater appreciation for the role of chiropractic research in your practice. Stay tuned for more episodes. If you have suggestions or comments about the show, please let me know.